Most of us have had a sore muscle at some time or another, so we can empathize with people who chronically suffer from muscle pain. According to NIH, 1 in 73 people, that's approximately 3.7 million Americans, suffer from fibromyalgia syndrome, a chronically painful disorder associated with fatigue and impaired sleep. In general, chronic muscle pain, especially that of fibromyalgia, is reported by patients to be aggravated by stress. How stress does this is unclear. Stress causes the release of various compounds to support the body in the face of a perceived threat. This includes glucocorticoids from the adrenal, like cortisol, and catecholamines from sympathetic nerves, like norepinephrine. We know that in fibromyalgia patients, glucocorticoids are not therapeutic and also don't appear to worsen the pain, so they're unlikely to be involved. However, catecholamines are known to support various types of pain. In addition, sympathetic nerves are excessively active in patients with fibromyalgia. One of the areas of the body that receives sympathetic innervation and that responds to both stress and cold is brown adipose tissue. This tissue generates heat as a protective response to cold and stress. Like the incidence of fibromyalgia, which is more common in females, there's a sex difference in the amount and activity of brown adipose. There's more brown adipose and it becomes more active in females than in males. We first noticed this tissue based on the overlap in the distribution of nerves projecting to brown adipose and those projecting to tender points that have been historically used to diagnose fibromyalgia. While patients claim to hurt all over, these sites represent areas that rarely hurt when palpated in healthy individuals, but often hurt in patients with fibromyalgia. Because stress activates sympathetic nerves that enhance brown adipose activity, we hypothesized that collaterals of nerves associated with brown adipose that project to surrounding skin and muscle can cause muscle pain. We tested this by subjecting mice to a 15-minute forced swim in cold water, a model traditionally used to induce stress. We measured muscle pain by decreases in their grip force immediately after the swim based on the premise that they let go when it hurts. These decreases reflect pain rather than strength if they're reversed by analgesic compounds. Shown here on the y-axis are the decreases in grip force responses in mice after a swim compared to immediately prior to the swim. These decreases were significantly less in control mice, indicated by the C, that didn't swim than in mice exposed to the swim. Because these decreases are morphine sensitive, this does suggest that swim causes muscle pain and not weakness. The middle two bars show the decrease in grip force in sham-operated mice compared to mice whose brown adipose was removed 2 weeks prior to testing. Removal of brown adipose attenuated the effect of the swim stress, indicating that the brown adipose is essential for hyperalgesia, that is, enhanced pain. The two bars on the right indicate that wild-type mice still have a lower grip force in response to swim. However, their littermates lacking the key UCP1 enzyme for brown adipose activity failed to respond to the swim. Based on these data, swim stress enhances muscle sensitivity to pain, but this effect is negated by removal of the brown adipose or by genetic elimination of the enzyme necessary for tissue activity. These converging lines of evidence suggest that activation of brown adipose tissue by stress may contribute to muscle pain and should be explored more extensively in order to develop better treatments for painful muscle conditions such as fibromyalgia.